Good morning, everyone. It is an absolute pleasure here to be in the Kingdom. I'd like to thank Dr. El Reyes and also Dr. Alizani for the very kind invitation to present here, the chairpersons, and thank you again for coming. So the task that I was actually given, Thank you. The task that I was actually given was to give you an update regarding the 2022 guidelines, the management guidelines for axial spondyloarthritis. These are my relevant disclosures. So my objectives are twofold. First of all, discuss what's new about the 2022 guidelines and how it can actually help us manage patients with axial spondyloarthritis. And secondly, and respectfully, I'd like to clear up some of the confusion regarding the first treat-to-target study in axial spondyloarthritis because it did not meet its primary outcome, and I think it has to be put in proper context. So those are the two things I'd like to do over the next 20 minutes. So just a case to ground us, and just for the sake of time, this is a 32-year-old lady that's got non-radiographic axial spondyloarthritis. She's got inflammatory back pain. It's affecting her function, and she's having difficulty at home as well as working as a nurse. She's B27 negative. CRP is normal. Pelvic radiograph does not show sacroiliitis, but thankfully, her MRI showed active bilateral sacroiliitis. So there's a suggestion that this is axial spondyloarthritis. She was initiated on adalimumab, and she's got a partial response. She feels better, is able to move a little bit better, is sleeping a little bit better, but is still having issues in terms of functioning. When she did her ASDAS score prior to initiation of biologics, it was 3.3. A repeat ASDAS at reevaluation at 4 months was decreased by 1 point, so it was 2.3. So the question is, can the present guidelines help guide us in terms of what to do? Do we switch therapies? Do we continue with the adalimumab? Do we potentially increase the dose of the adalimumab? So let's look at the guidelines to see if there is any help that we can actually get. So the first thing regarding the ASAS-ULI recommendations regarding management is that this is an update. As you may be aware, it was initially conceived in 2006. It was refreshed in 2010. And in the most recent, prior to this particular update, the most recent one was in 2016. Lots happened between 2016 and now in terms of emergence of new classes of therapy, as well as change some of the construct in how we actually think about axial spondyloarthritis. So it was very timely to have an update and discuss what's new. So when you actually do a management guideline, what's there are 5 overarching principles which have not changed at all. We'll just touch on it based on one slide because if it gives you a general sense of what it is that you actually want to do when you are managing axial spondyloarthritis. In total, there are 15 recommendations, 8 of which have not changed, 3 had minor changes, 2 had relevant updates, and we're going to look at these a little bit more, and 2 had new recommendations, and we'll certainly touch on those. So in terms of methodology, just very quickly, they followed the EULAR standard operating procedures, which were developed in 2014. So they did 2 systemic literature reviews. One looked at the efficacy and safety of non-pharmacological as well as non-biological interventions, and the other regarding the efficacy and safety of biologic DMARDs. There was a task force meeting that occurred virtually over a day, and the level of evidence and the grade recommendations were reported according to the Oxford Evidence-Based Medicine. And based on the experts, they looked at the level of agreement from 0 to 10 and the percentage that had at least 8 out of 10 improvement. So these are very standard. What were the overarching principles? So it's nice to go over it again, that for axial spondyloarthritis, it is a systemic disease. There are multiple disciplines that are involved. We should have a multidisciplinary management that's coordinated by the rheumatologist. You don't have to do everything, but it's nice to have a team around you to actually look after these patients. Not only are we interested in signs and symptoms, but we also want normalization in terms of function and social participation, both at home and at work. We should think about management globally, non-pharmacological as well as pharmacological treatment. It's important to get the patient's perspective. So this issue of shared decision-making, as it was noted by Dr. Attar, is very, very important. And finally, unlike the ACR guidelines, the medical as well as societal costs were put into perspective. So this is not solely about the patient. This is about the global or societal good as well, and that was considered in some of their decision-making. So it's a difference in terms of some of the two different guidelines that are the most commonly cited. So when you actually look at the table, what I'm going to do is just look at this in slightly more detail, but I want you to respectfully make you familiar with the table. And the thing to get from this particular table is that there are 3 phases that are there in terms of the management recommendations. So what's the first phase? The first thing to remember, we certainly have classification criteria for axial spondyloarthritis developed by the ASAS group. But please remember, these are classification criteria for putting patients into clinical trials. You are the gold standard when it comes to making the diagnosis. Axial spondyloarthritis is a clinical diagnosis determined by the rheumatologist. If you make the diagnosis, it's proper to tell the patient this is what they have, because the more the patients know about what they have, the more empowered they'll be, and the more educated the patient is. That is really what provides the best outcome in terms of patient. Second thing is to make sure that they have regular exercise and they improve their lifestyle, particularly in terms of non-smoking. One of the minor changes that has occurred is that previously physical therapy was encouraged. It is still encouraged, but some people misused physical therapy as knife treatment or needle treatment and all sorts of alternatives. And they wanted to specifically state what they meant, which was physiotherapy. So the term physical therapy is now changed to physiotherapy, and this was done by design. So if you have axial spondyloarthritis and you're symptomatic, you try anti-inflammatories initially on a PRN basis. If you continue to have symptoms, you increase the dose and take it on a regular basis. If it hasn't worked for a couple of weeks, you can try another anti-inflammatory agent. So that's typically what we do. So what happens when you continue to have symptoms despite 4 weeks of NSAID management? Then you look at the patient critically and you ask yourself, do you have an elevated CRP, or do you have an MRI that shows inflammation? Why are they looking at this? Because these are predictors of good biological response. And historically, they've also looked at radiographic sacroiliitis. Even though this is not necessarily a predictor of good response, this is maintained in terms of things that you actually look for prior to initiation of biologic therapy. How high does your disease activity have to be? Previously, we used a BASDAI score of 4 or greater. Another change that's occurred now is instead of the BASDAI, they would prefer to use the ASDAS of 2.1 and greater. Why the ASDAS? Because it does have an objective measure of inflammation, which is the CRP. Also, the ASDAS better correlates with syndesmophyte formation or radiographic damage. So they feel that the ASDAS is superior to the BASDAI, and they have made that change of ASDAS greater than or equal to 2.1. But still, there's a fair bit of patient input in terms of the ASDAS, so you have to interpret the ASDAS in the context of the patient and making sure they don't have, for instance, concomitant chronic pain, which may actually alter how you interpret the ASDAS. So in the context of someone that actually has ASDAS greater than 2.1, has some objective sign of inflammation, the first thing to ask is this primarily a peripheral joint involvement? And if it is, if it's oligoarthritis, you may want to inject, for instance, with glucocorticoids, those joints. Or if you have a polyarticular disease, you may want to initiate sulfasalazine. If it's primary axial, then you consider using biologic agent. So what is it they're saying in terms of initiation of biologic agent? So one small caveat is that if you cannot do the ASDAS because you don't have the CRP at hand, then you can still use the BASDI of 4 or greater. Because there is no randomized controlled trial, according to the ASAS group, between TNFs, IL-17s, and the JAK inhibitors in terms of the 3 classes that are actually on the market now for treatment of axial spondyloarthritis, they're saying that you can use any of these. However, there's a caveat, and the caveat is that there's a long-standing practice, and the usual practice is to use TNF inhibition or IL-17 over JAKs, primarily because of the duration of use, our experience, and more recently because of the oral surveillance study with some of the adverse events related to JAK inhibition. A new recommendation is this, and that is regarding extramusculoskeletal manifestation. Previously, we used to call it extra-articular manifestation. They've actually removed that term. The reason being is some people confuse comorbidities, such as cardiovascular disease or depressive symptoms into the extramusculoskeletal manifestations, which were uveitis, IBD, and psoriasis. Because these have direct treatment implications, they wanted to separate comorbidities from these organ manifestations. So nowadays, these are called extramusculoskeletal manifestations. If you have recurrent uveitis, they're suggesting monoclonal antibodies targeting TNFs. If you have active IBD, they're again suggesting TNF monoclonal antibodies. And if you have psoriasis, strong consideration should be given to IL-17 therapy. And that's because of the 2 head-to-head randomized controlled trials showing that the composite score of IL-17 was superior to TNF agents. So what happens in terms of reassessing these patients? They're suggesting, please wait at least 12 weeks before you see them. Secondly, you have to assess disease activity, and the minimum improvement that they're actually looking for is an ASDAS improvement of 1.1 or greater. And again, you actually have to interpret the improvement in the context of the patient. Okay, and it's also your gut feeling along with the score that actually will determine a go or no-go regarding potential change in therapy. So, and again, there's a little caveat in terms of if you can't do the ASDAS, then what you're actually looking for is a BASDI change of 2 or greater. So, if you actually need a biologic agent, just make sure, please, that you've actually reached an ASDAS score or a BASDI. So what happens in the setting where your ASDAS score is less than 1.1? And this recommendation is going to be new, which is recommendation number 11. As confident as you are, to be quite honest, sometimes we're not quite sure, particularly in terms of non-radiographic axial spondyloarthritis. So what they're actually suggesting is please re-evaluate your diagnosis just to make sure you think it's actually correct, because these diseases respond so well to biologic agents. If you're not a non-responder, think again that you actually have the right diagnosis. Secondly, think if there's any other contextual factors that may be throwing you off. And so you need to consider this before jumping to changing therapy, whether adding some sort of NSAIDs or changing biologic therapy altogether. So, if the patient continues to have active inflammation, and you think that this is due to active spondyloarthritis, what is it that you do? Again, in the absence of head-to-head studies in terms of a switch, you can consider TNF agents. In other words, you can switch within class, you can switch outside of class, and it's open to TNF inhibition, IL-17A, or JAK inhibition. Again, with the caveat that with JAK inhibition, be a little bit careful because of the adverse event profile, and the current practice is to actually use TNF or IL-17A, but all options are on the table. What happens if the patient has done really well? Then you can consider tapering. When to taper is really your decision. There's no firm guidelines, but you want to make sure that the patient is actually in remission. There's no clear criteria for remission, but you should at least reach low disease activity for at least about 6 months. We usually do it a little bit longer. So if you have reached remission without any clear criteria, for that period of time, you shouldn't just stop the biologic agent, because that's likely going to cause a flare. What they're suggesting is a taper. Okay, you increase the dosing interval. Once you've increased the dosing interval, please reassess the patient. If they seem to be doing well, you may further increase it. And at some point in time, you may discontinue, but just not discontinue just because they have reached low disease activity over a 6-month period. So what these guidelines have done is that they've given you a fair amount of leeway, because at initiation of biologics, they've given you the opportunity to use any of them in the proper context. If they fail therapy, again, in terms of biologic switch, they've given you a fair bit of leeway so that you can put it into context of your particular setting. So it's quite reasonable, and I think some of the changes really are logical. So I'm just going to switch gears just for 1 second and talk about the TICO-SPA study. So this was the first, and it's the only, treat-to-target study in axial spondyloarthritis. We all understand the concept of treat-to-target because of rheumatoid, as well as to some extent psoriatic arthritis. Really, the target in terms of remission is not doable given our response rates, because we're going to actually switch therapies too often. I think that a more realistic target is persistent low disease activity. And so they did a pragmatic, prospective, sort of cluster randomized study, and it was open and it was a controlled study. It was primarily European countries, so France, Belgium, and I think Netherlands that were used. So the treat-to-target arm, you're actually seeing them every month, and the target that they picked was the ASDAS score of less than 2.1. The control arm, you'd see every 3 months, and the physicians would treat them just according to how they felt the management should be. The only caveat here is that these were highly trained physicians in terms of their management, and they may have had some bias in terms of being very up-to-date in how they treat the patients. The outcome that they were actually looking for is at least a 30% improvement in the ASAS Health Index, which is a questionnaire of 17 questions that you ask that takes about 2 minutes to fill out. They also looked at other relevant outcomes, such as secondary outcomes, adverse events, and health economic evaluation. So they had 9 centers in each of the groups. So you would randomize the center, not so much the patients, because within each center you want to treat the patients the same. They had about 80 patients in each group. They looked at the results a year later, and what you find is that there's no statistical difference, even when you actually adjust for cluster randomization, but there is a numerical difference. In other words, treat-to-target did better numerically, 47% versus usual care, which is 36%, but not statistically. So to say that there is absolute evidence that treat-to-target is helpful, it's not there, but there's certainly a trend. In terms of other outcomes, you used more biologics if you did treat-to-target. It was similar in terms of side effects. The biologics have become safer and safer in our hands and how we use them. Interestingly, in terms of a health economic analysis, because of indirect cost, it was the treat-to-target arm that was found to be more cost-effective from a societal perspective. 2 things to think about, however, and this is a sub-analysis that was presented by Martin Rudwright in the last ACR, and this is looking at studies that were done some time ago with certolizumab, and that when you look at objective measures in terms of CRP or inflammation as characterized by the MRI in the spine or the SI joints, you have more than a 50% improvement, which is in the blue, or more than 75% improvement in the gray when you're actually looking at the CRP or the MRI score. So there's great improvement in terms of our objective score. When you look at it, clinical disease measures, okay, there's still a large number of patients that are not receiving over 50% of the improvement. So why the discordance? So one of the things to actually think about is these contextual factors. So there's a really nice study here that looked at depression based on the HADS, a depression scale, and if you have even mild and moderate to severe depression, your odds of reaching a BASDAI less than 4 or an ASDAS less than 2.1 are quite a bit less, and your survival is a lot less if you have mild, and even more if you have moderate depression. So we certainly don't want to take away therapy if, for instance, through behavioral modification, you can actually treat depression because you don't want to cycle meds too quickly. So we are very good at looking at axial disease, looking at peripheral disease, looking at extra-articular manifestations. We really have to train ourselves and to help coordinate a team to look at what's on the left-hand side, depressive symptoms, fatigue, and if needed, look at the social context of the patient. So just coming back to the patient, what was actually going on with this 32-year-old nurse? What was happening is that the father passed away. She was looking after her mother. Her mom was incontinent. She was up a fair bit of the night changing her bed sheets. We called the family physician. She decided to put urinary catheterization for the mom. The patient was sleeping better. She did really well. And so it really, in terms of her inability to function at work, had very little to do with her active disease and had to do with the social context of a mom that she was looking after at night. So please consider not just the disease, but other things that can potentially be happening with the patient. So finally, there are still things that the guideline unfortunately does not address, but it's not an issue with the guidelines, it's just that we're missing certain key data attributes. It'd be really nice to have, as you initiate biologic agents, head-to-head studies in between the treatment options in terms of what to choose first. If you were to fail the first biologic therapy, it'd be nice to know what to do next. I think we need more clarity in terms of JAK inhibition and inhibition in terms of IL-17 regarding extra musculoskeletal manifestations such as uveitis. The impact of comorbidities in terms of treating these medications are important. But the biggest challenge that we actually face is when you have concomitant fibromyalgia or chronic pain, how do you assess disease activity? Because all of a sudden what we're asked to do in terms of looking at the ASDAS or even the change in BASDAI score, we're sort of guessing and using our own gestalt to then looking at the score, and it'd be nice to have a more objective measure. Thank you so much for your time.